Good afternoon, everyone. My name is Tia Teriak. Welcome to What's Up, Doc, a monthly lecture program brought to you by the Concord Hospital Trust. Today is Veterans Day, and we want to pause and extend our deepest gratitude to all veterans. Thank you for your courageous service to our country and for the sacrifices you made defending all the freedoms that all of us enjoy every day. And I also want to stop and recognize Joe and Ann Farrelly, longtime supporters of What's Up, Doc, familiar faces to you. Today they celebrate their 69th wedding anniversary. Wow. Concord Hospital Trust would like to recognize and thank the Walker Lecture Series for their very generous sponsorship of What's Up, Doc. The Walker Series offers lectures on history, literature, art, science, as well as dramatic, musical, and literary performances. All events are free to the public. They're held at the Concord City Auditorium. We encourage you to go to their website and check out their schedule of programs. They've got 3 wonderful holiday things coming up. What's Up, Doc is proud to welcome back Dr. Ari Salis. The last time Dr. Salis was here was Friday, March 13th, 2020. We all know what happened the very next day. But we're proud to have Dr. Salis back with us today. Dr. Salis' specialty is interventional radiology. He attended medical school at Rutgers College in New Jersey, where he graduated with high honors. Dr. Salis completed his residency at the University of Maryland Medical School, and then he completed a fellowship in interventional radiology at Indiana University School of Medicine. Dr. Salis joined Concord Hospital Health System in 2015. He is currently serving as the chairman of radiology and the director of interventional radiology. Today, Dr. Salis will share with us interventional radiology treatment options for vertebral compression fractures. Please join me in welcoming Dr. Salis.
Thank you. So I just want to thank the Trust for this opportunity, and just to add a little bit of historical background. So this is my 3rd time giving this lecture, and you heard about the 2nd time with where we all went ahead and had the whole lockdown. But the first time, while I was up here, my daughter had a lacrosse ball implanted into her eye and was in an ambulance going to the hospital, and my pager was going off and my texts were going off. So don't worry, we're safe. Yeah, nothing crazy will happen today. So as she mentioned, I'm an interventional radiologist, and we have a really strong interventional program here. I've been here for about 8 years. We have a real solid team now, and some of them are in the room. We have office staff that are in the room. We now have an official office for interventional radiology. There's even a name tag that says it on the door. And then behind them is my whole staff in the room, which kind of works like an operating room. And so you have nurses, you'll have technologists, we have nurse practitioners, physician assistants, all part of the team. So it went from really where there was barely any cases happening, and now we have a robust program, and it's not just me trying to push the envelope, but it's really everybody that's involved, which is a really great thing for our Concord Hospital's community. So first we'll get into what an interventional radiologist is, because majority of the time it's very perplexing to people. So everybody knows what a radiologist does. You know, a radiologist uses imaging to make diagnosis. And so you can have radiographs, computed tomographic imaging, which is a computed program of X-ray imaging, making small pixels and creating an image. Ultrasound, magnetic resonance imaging, and nuclear medicine, where you use like radio tracers attached to a molecule that somewhere is moving through the body, and determining activity because of that molecule that's linked with the radio tracer, and you can identify it and see it on a screen. So interventional radiologist uses all those imaging modalities, but instead of just diagnosing, we can also treat. And so now we're a board certified, separate from radiology, although still inclusive, but now is truly a subspecialty on its own, just like you would have gastroenterology or even cardiology. And we're the inventors of angioplasty and stenting, and the purpose of interventional radiology is really, the bottom part here is where we pioneer minimally invasive techniques. And that's something that you've seen throughout medicine in the past 20, 30 years. So how is it created? So it's 4 years of college, 4 years of medical school, and then the interesting component that's changed since I've been giving this talk here is it now has its own residency. So you can go straight into interventional radiology before you would go into diagnostic radiology, and then you would go into interventional radiology afterwards. But now, being its own subspecialty, you can have medical students that are just following the track of interventional radiology, which is something brand new in the past few years. So the main purpose of being an interventional radiologist, at least in my mind, is trying to figure out procedures that we can do to kind of offset the standard and do it where it's minimally invasive, decrease complications, decreased hospitalization, and improved outcomes, better than what the standard is. So when I'm on the volleyball court watching my daughter play and somebody comes up to me and asks me what I do, and I say, oh yeah, I'm an interventional radiologist, I get like, oh, okay. And so they're like, well, what does that mean? So what I usually say is surgery without the mess. So no big incisions, postoperative complications are less pain and trauma to the patient, less time in the hospital, and patients back to their life. So this is the new term now. I asked my daughters, I used to have cool up here, but now they say, why is it fire to be an interventional radiologist? So the advantages of my specialty is that I'm not tied to any body part. We treat all different disease processes, all different parts of the body, and the only thing that limits us is the image component that we are doing these procedures with. So there's no real limit at all. I could be working on a patient and draining an abscess and then going ahead and treating a spleen that's bleeding, and then moving next to working on like doing a lumbar puncture. So it's really a great field in terms of the fact that we're not really locked in a particular space. So why is it tough? Just like the person at the volleyball court, even my mom, even though I'll say it over and over again, she just doesn't get it. A lot of people don't understand it because it's kind of different from other specialties in medicine. Most specialties in medicine are tied to a body part. If you're going to have a bone issue, to go see an orthopedist. If you have a stomach issue, you'll see a gastrointestinal doctor. A heart issue, you see a cardiologist. But come to an interventional radiologist, is like, do I have an interventional problem? I'm not really sure. So that's kind of hard for our specialty. But I think the advantage is that we are kind of all over the place in treating patients is worthwhile for that. And that's why I give these kind of talks, is to kind of educate everybody and know what we do. So what do? So as I mentioned before, we try to go ahead and take a standard way of treating patients and think of a better way to do it, in a better way where it's minimally invasive and less complications and improved outcomes. And so I'm just going to go through a few of these. So abdominal aortic aneurysms. In the past, it would be a real big surgery. Recovery would be really tough. Big incision across the abdomen, and to put in a bypass graft. And these days, what we can do, and it's now almost becoming the gold standard, is we can go ahead with tiny incisions in the groin and put up a mixture of a stent and a graft. And so without a big surgery, we can go ahead and completely bypass the aneurysm and the patients can go home in a day. Sometimes I've had patients go home same day, versus being in the hospital for weeks and recovery being 6 to 8 weeks. Cancer treatments, things that we do, we place ports for patients that have to have chemotherapy. In the past would have to have IVs, and those IVs would blow and have problems with getting access. And so we can put a device in the skin that we put in with X-ray and ultrasound so that they can have the chemotherapy. We also do treatments where instead of having chemotherapy or radiation, we can target locally right at the disease, right at the cancer. And we do that here where we do something called cryoablation, where we freeze the tumor. We can also use heat to destroy the tumor, and something called microwave ablation or radiofrequency ablation. And it has equal, or if not better, outcomes than doing it the old way with maybe having surgery to remove those tumors. Abscess removal. This is something that interventional radiology has been doing for years, but in the past, the patient would have to go back to the operating room to have the abscess removed. Now we can use CAT scan or ultrasound imaging, and we can guide a small needle right into the abscess, and then from that needle we put a wire in, and then we remove the needle, and then over the wire we put in a small tube and drain the abscess out. And so there's no additional surgeries required. It's something that can be done either with mild sedation or even sometimes just locally numbing up the area. So it's significantly changed any kind of post-procedural complications with regards to surgical abscesses. Infertility. We treat patients with something called fallopian tube recanalization. So if the fallopian tubes are clogged, we can go ahead and we can put a small little catheter in and unclog it. And I've had several patients where we do these procedures, and 9 to 10 months later down the road, patients will come in with their baby, and that's very gratifying. Biopsies, we do all sorts of biopsies, and we use image guidance to do that, where we can snake a little needle wherever we can get it and get a sample versus doing like an open incision. So that's really changed the whole process of biopsies, I'd say in the past 20 to 25 years. Patients with pelvic pain, sometimes women can develop almost varicose veins that are in the abdomen and can cause pain and pressure, and we can go ahead and use small little coils and stop those blood vessels so that you'll decrease the blood flow going to the pelvis and decrease the pain. And it's a new procedure that before we were doing it, there was no procedure at all for treating those, or it was a significant surgery. Spine fractures, which we'll get into a little bit later because that's why we're here. Varicose veins I talked about before. In the past, the gold standard was stripping, which was a procedure in the operating room with anesthesia with a significant downtime. We now do that in the office, and we have people from the office that can even guarantee that we do it there. And it's minimally invasive. Patients have no downtime, and the procedure is less than 45 minutes. Uterine and prostate. So why are they combined? Because we can do the same thing. Sometimes the uterus will develop benign tumors, and the uterus will get enlarged and cause significant bleeding, mass effect symptoms where increased urinary frequency and increased pain. And instead of having a hysterectomy, we can go ahead and put small little catheters into the blood vessels and then inject small particles to shrink down those fibroids. And so the patients don't need to have their uterus removed. And it's a significant improvement that's been happening for about 20 years. It's now, even when we first started doing it, there was some hesitation from a lot of the gynecologists saying, I don't know if this is really legit. In fact, one gynecologist told me in front of a medical staff that I was performing witchcraft. But now it is also approved, and if you looked on the gynecologist website, you'll see that this kind of procedure is out there, and it's well proven, and it's really something special that we offer. And the same is now for prostate. So for the past 5 years, we've been going ahead and now shrinking down the prostate in a similar fashion. So patients that have urinary frequency or other like urinary tract infections, we can go ahead and decrease the prostate instead of surgery. And this works really well on patients that have large prostates. And large prostates aren't really a good way to go with surgery anyway because there's increased complications. So it kind of works hand in hand, and we're doing that here at Concord Hospital. And then the main reason that I was brought up here was because we're a level 2 trauma. And so we're highly involved in trauma care here at Concord Hospital, so much that some people can attest. We were here at 1 in the morning last night treating. So yeah, it's a busy trauma practice here, and we're happy to be involved. So this isn't a Weight Watchers commercial here, but on the left side is the aneurysm, and it's in the aorta, and so this whole component is all the aneurysm. And the reason we want to treat this is because it could rupture. And so just like I mentioned before, we're able to make tiny incisions at the groin and then bring up a stent graft. And now that's what you have in here. And this is a little catheter that's in there and marking so we know how to make our measurements. And so the entire aneurysm is now bypassed and flow is going through. So without surgery, and really downtime is very low, and the results are pretty wonderful. It's probably equal to surgery in terms of the outcomes. So today we're going to focus our attention on spine fractures and how interventional radiology is involved in spine fractures. So compression fractures is the main object of what we're going to be talking about today. And this is a MRI, and in the middle you can see this area where it's decreased in intensity is the compression fracture. You can look at this vertebral body and how square it is compared to this one. And so that's what we're going to focus on today. This is another artistic rendering. So on the left side is what your vertebral body should look like. And then what happens when it's fractured. So it has a wedged appearance. And instead of the force coming down like this, there's force moving forward, which we'll talk about later, what can happen to the spine over time when you develop fractures like that. And so what's called vertebral compression fracture. So that's what you're seeing up there. So the causes, so the number one cause is osteoporosis, which we'll get into the definition, and I'll show you a slide to kind of give you a better idea what that means. But that's the number one reason that we're treating compression fractures. And then cancer can also invade the bone and weaken the bone. And we call that a pathologic fracture. And that's probably a good second for the chance that developing a compression fracture. And when we go ahead and treat these, which we'll get into, we always do a biopsy because sometimes cancer can be kind of lurking behind the scenes, and it's very hard to diagnose on the imaging. Trauma can do it too. Usually with trauma, it's sometimes connected with the primary cause of osteoporosis. And then benign tumors, which like something called an hemangioma, which can just weaken the bone, and then over time with pressure can result in the compression fracture. So as I mentioned, osteoporotic fractures are a significant issue in the United States, and very much an issue here in Concord. It's because of the aging population here in New Hampshire, we're seeing a tremendous increase in vertebral compression fractures. And the number one cause of vertebral compression fractures is osteoporosis, and the number one reason that you'll get injury from osteoporosis is the vertebral compression fracture. It happens 1.4 million worldwide, and the health cost, that's probably a low number, 1 billion. It's probably even more than that. So primary osteoporosis. So it's mostly related to elderly patients, females more than males, whites more than African American, and risk factors are alcohol, excess caffeine, and smoking. Secondary, and we'll see this many times, is patients that are usually on chronic steroid use. So I gave a couple examples, asthma, organ transplants. Not too long ago, we just treated a patient with a cardiac transplant that was on steroids for a long time and developed vertebral compression fracture. So here's the true definition. And what I wanted you to really focus on is what normal bone looks like, and it's this trabecula pattern and how thick that is compared to in somebody that develops osteoporosis, how thin it gets. And you can see that this becomes brittle and how you'll have an increased risk of developing fractures. So as I mentioned, it's really an epidemic. There's some data to say that your risk for hip fractures for women is higher than for the risk for breast, uterine, and ovarian cancer combined. And it's the 12th leading cause of death in older women. And the reason for that, you say, well, how could that cause death? It's really because if you develop fractures, you could be bedridden. You're not going to ambulate as much. You're going to get depressed. And that kind of causes this spiral. So the signs of vertebral compression fracture. So a lot of times patients will come into the office and they'll be like, well, I wasn't doing anything, and all of a sudden I just had pain in my back, so how could I really have a fracture? And that's the issue with osteoporosis, is that patients can just get up from a chair, and that can be enough pressure on the vertebral body to cause it to compress and to develop a fracture. But we sometimes will see an event where patients say they were getting out of the car, or they were sometimes in a tree. I've had stories. Or on the roof, but a lot of times it's just doing everyday kind of processes, like doing your shopping, picking up your groceries, or bringing the wood in. So the treatment. So the way that most providers want to look at this is say, okay, we'll try to be as conservative as possible. And so the best way to treat these patients, the assumption is bed rest, back bracing, and then pain medication. So we'll go through. So bed rest. So the problem with bed rest is that it doesn't really help too much with the pain. A lot of the patients will say, yeah, I'm doing great as long as I just sit there in my bed and don't move at all. But the minute they move, that's what happens, is the fracture continues to shift and cause the pain. So it doesn't really cause a long-term functional improvement for patients. And then just laying around, you get more bone loss. Bracing. So a lot of times you'll see providers go ahead and say, okay, you have a fracture, we'll go ahead and we'll put this brace on and come back in 4 weeks, we'll see how you're doing. So there's been several studies that shows that bracing is really not that effective. And so the first study that I show you here, they compared bracing versus non-bracing in patients that had acute vertebral compression fractures. And after eight weeks, there was no difference in pain. And then there was another study back in 2014 that looked at 2 different kinds of braces, as well as no brace, and it was the same, and that was after 12 weeks. There was no difference in reducing pain. So I'll have some patients that come into my office, and what usually sometimes happens is patients will come to us later in the stage, where they are trying this non-surgical management and realize that it doesn't work, and they'll be coming in and they'll be wearing a brace. And some of the patients, which we'll talk about in a bit, maybe they're hunched over because they've had other compression fractures, and the brace is rubbing their skin, and it's not helping, and it's just hurting more, and so we just get rid of the brace. So pain medicine, also not a great thing when you start talking about opioids in elderly patients. There's an increased risk in falling. Many times patients are on blood thinners these days, so you can get an increased risk in like head injuries because of the falls. You can develop constipation, cognitive impairment, and dizziness. We all know about the addiction, and also respiratory depression, and can lead to like pneumonia. So this is what I was talking before about, is a downward spiral. So somebody develops a vertebral compression fracture, and then they wind up going ahead and just not doing anything that they've been doing before, laying around, less quality of life, difficult breathing because of the compression fracture narrows the thoracic cavity, can develop pneumonia, depression, and at the end of the spiral is mortality. And there's definitely evidence showing that treating patients with non-surgical management leads to increased mortality and death. So as I mentioned before, if you have thoracic vertebral compression fracture, it narrows your cavity of expansion of your whole lungs, and just one fracture can drop how you're breathing about 10% less. The other problem is the quality of life. So many patients that I see come into the office and say, I'm not able to do my daily function. I'm not able to be independent. And that leads to depression, low self-esteem. And so that's many of the issues that we're dealing with our patients. So the biomechanics. So what happens with a compression fracture is the bone is weakened, and usually with the way the bone is structured is that the force is on each entire vertebral body, and that's this axial force, and the bones are able to maintain that and limit any force going forward. But as the vertebral body narrows down, you develop this compression deformity, and the force changes, so it starts to lean in a way where it's kind of almost like a C shape. And that C shape that we're having, that curvature, is called kyphosis. And it gets worse as the vertebral body narrows down even more. And the force continues to go because the vertebral body's alignment is off, so that force is now being directed more forward, and you start seeing how some patients are hunched over or kyphotic. And so this is an example of a patient at age 50 versus 75 with multiple compression fractures, and you can see how the spine has changed. And it's not just in women, you'll also see it in men. So non-surgical management doesn't really work well. If somebody has a painful vertebral compression fracture, there has to be a different way to treat these patients. So this slide shows there was 5 studies. It's called a meta-analysis, where they took 5 studies together, and they went and they said, how's non-surgical management work? Everything we just talked about, the bracing, the steroids, the opioids, and the NSAIDs. And doing that, there was no quality evidence of benefit. And then, as I mentioned before, at 1 year, there's a 55% chance of increased mortality compared to non-surgical management. So we had to figure out something else. We had to go ahead and find a way to help these patients. So that's where we invented vertebral augmentation. So vertebral augmentation is a fancy term for 2 procedures that we do. One called vertebroplasty, the other one kyphoplasty. And so this is a picture of cement in the vertebral body after a kyphoplasty. So the first thing that we want to do, as I mentioned before, is you can have compression fractures without any pain. And the patients that we're looking to treat are the patients that are in pain. And so patients come to see us either in our office or we see them in the hospital. And the biggest questions that we ask are, how is your life changed because of your pain? If you're limited to the bed, if you're not able to do your job, if you can't get out and drive, those are all those check boxes that we hit to say, it looks like you're going to be a candidate for this procedure. Also, what kind of medications are you on? Are you taking opioids? Are you on those kind of narcotic medications? So the best candidate is somebody that has this suffering, quality of life issues, and has significant back pain that we can point at where the vertebral body is compressed, and that aligns up. So if you have the symptoms and the physical findings on physical examination, and then also we correlate it with an MRI, where we get a scan to look at what the fracture looks like. Because as I mentioned, with osteoporosis, they may have multiple fractures, but we're looking for the one that's really causing the issue. So this is an MRI, and it has a specific sequence called T2 stir. And what it's doing, this sequence is having us evaluate edema or fluid. So everything that's bright has a lot of fluid, and it's inflamed. And so this vertebral body has a significant amount of fluid, and it's showing this brightness that we say is increased in intensity. And many times we get this in order to determine where we're going to go in treating these patients. And surprisingly, sometimes you'll see a compression fracture and you'll say, oh, okay, that's the one we're going to treat. And then we go ahead and we do the MRI, and it's actually the one below that that's not really significantly compressed, but is actually like an early compression fracture, and that's the area that we're going to treat. So for every patient, we try to go ahead and get imaging in order to link the imaging with the physical diagnosis. If a patient can't have an MRI, then the next scan that we usually do is a bone scan. And so what we have is we have a molecule that is very active when there's remodeling of the bone, when there's a fracture. And we tag that with a radio tracer, and we inject it into the patient's IV, and then we image about an hour later, and it can show us where that active fracture is. And we sometimes go ahead and we fuse those images with a CAT scan, and we're doing that here at Concord Hospital, so then we can definitively see what vertebral body we need to go ahead and treat. So the reasons that we wouldn't do a kyphoplasty is if somebody doesn't have any significant pain. That's, if somebody came to me and said, well, I'm able to do almost everything I can do, then that would be a reason to go ahead and perform conservative therapy initially and see how things go. And there's no rush, and we can always determine if the pain's getting worse, then they can revisit us and see if it's a potential candidate for the procedure. Another contraindication would be if the vertebral body gets so tight that the compression is so limited that it's difficult for us to get our small introducer set in there. And another big problem that can happen is usually when the vertebral body compresses, it stays aligned with the spine, but sometimes it can pooch backwards. We call this retropulsion. And so it can push against the spinal cord. And if you go ahead and you put any substance in there, like cement, there's a potential that it could even push it back more. So then we try not to do any kind of procedures on these patients. So how did it come about? Like first, there was a inquisitive doctor in France, and a lot of procedures some reason invented in France. But in 1987, with a benign tumor, they thought it would be a good idea to stabilize that with injecting cement. And so they did that, and the patient did wonderfully. And from that period of time, it kind of expanded to where we started doing it in 1997. And so the pictures are kind of showing the introducer and then injecting the cement into the vertebral body to stabilize that fracture. So the benefits of vertebroplasty is that it's a very quick response. It's very inexpensive. It can be done as an outpatient. Again, it's less invasive than surgery, which is a theme of interventional radiology. Patients can be back to their daily function very quickly. The complications are very low. I used to always treat with steroids prior to vertebroplasty, and these days, even with kyphoplasty, which is a procedure that now we're doing, I don't do any steroid administration at the time of the procedure. What can happen, what we're doing is we're injecting cement to stabilize this fracture. So the cement can go in places that we don't want it to go. And so an example would be cement getting into the canal close to the spinal cord and causing compression on the spinal cord. The other thing is that a bone is really a big vein. And so usually there's a lot of production inside the bone making our blood cells. And so there's veins that are connecting to that and sending it out to the body. And so with vertebroplasty, when we were injecting the cement, it was kind of thin. So it kind of went places that we sometimes didn't want it to really go. And it would kind of get out into those veins. And if it gets into the veins, it can get up, it can go up into the heart, it can get up into the lungs. So that's something that's why when we do this procedure, we do it under X-ray guidance, so we're able to visualize that. And that's a risk of this procedure for not just vertebroplasty, but for kyphoplasty also. So as I mentioned, so the cement is thin. It sometimes can go in places that we don't want it to go. And what was not happening was we weren't trying to expand and increase the height of the vertebral body. We were just kind of stabilizing the fracture. So we came up with a different way to kind of tackle some of the issues that vertebroplasty wasn't really helping us with managing patients. And that's kyphoplasty. So it's a very similar technique, except what we do is we go ahead and create a void by putting a small balloon into the vertebral body and create a space where we can put the cement. And what that does is it decreases the risk of the cement going outside the vertebral body. We can also put in cement that's a little bit thicker, kind of like toothpaste, instead of really thin. So it decreases that risk of it getting into the veins. So kyphoplasty was first started here in the United States in 1998. And the procedure is typically an hour, can be a little bit longer, but mostly about an hour. We typically do the procedure with moderate sedation, so similar to like a colonoscopy. And depending on some patients, if they're sicker, then we'll do it with general anesthesia and have their assistance with doing the procedure. And this is a picture of a kyphoplasty where we have the balloon inside the vertebral body. And I brought one of the balloons. I don't know if we're ready to pass things around yet, but this pretty much is what the balloon looks like, and this is a device. So we'll blow that up, then we'll bring the balloon back down and remove it, and then go ahead and put in the cement. But I'll show you how that works. So the patients will come in the day of the procedure, and we'll get an IV. We'll bring them down to the Interventional Radiology suite, which we have this gorgeous room, and we have great imaging so that we can go ahead and visualize the spine. And we'll numb up the skin, and we'll place a small introducer into the vertebral body. We'll go ahead and do a bone biopsy at that time. And then after the bone biopsy, we'll place the balloon in. And then we remove the balloon, and then we go ahead and inject the cement, so kind of packing the cement into the vertebral body. We used to do it where we would do it on both sides, like that. So the cement would go in kind of, some people call it H-shaped, like an H. And so you would access from both sides of the back of the vertebral body, called the pedicles. Now, these days, we try to do it where we could do it unipedicular, where we go in through one tiny incision and get right into the middle of the vertebral body. And it's called, it's still kyphoplasty, but it's called unipedicular kyphoplasty. So let's see if this will work. All right, here we go. So first we're seeing osteoporosis. So you see first the bone was thick, now it gets thin, then it develops the compression fracture because of the thin osteoporotic bone. There goes the balloon, and it inflates and it expands, increases the height of the vertebral body, and then the balloon comes out, and then an introducer for the cement comes in, and you can see how that goes in. It's kind of thick, it looks like toothpaste, fills in, and there it goes. And that's kyphoplasty. So the first case I'll show you is an 88-year-old female, had increasing back pain, difficulty with sitting and extending her back. Pain was 9 out of 10. She was living independently, able to do everything on her own. However, after her compression fracture, she wasn't, and she was actually brought to Concord Hospital via 911 because it was difficult for her to even get out of her house. And she was admitted, and we went ahead and we went and saw her directly from the emergency department, which is something that we've been doing here. We're trying to decrease hospitalizations so that if the patients come in, we can quickly see them, assess what's going on, get them treated, and sometimes get them home much sooner than how things used to be. Sometimes what would happen, people would kind of fall in line and say, okay, we're going to go ahead and non-surgically manage these patients, and we'll wait 4 or 5 days. And then if it doesn't get better, we'll call interventional radiology. But what's clearly been happening is that we need to change that idea, and we need to get patients treated sooner so their pain goes away, and so they're not staying in the hospital for 4 or 5 days, and they're getting home a lot sooner. So for her, there was 2 areas, 2 light bulbs lighting up. So 2 compression fractures. And so this is how we treated one of them, and this is the balloon inside, and we're seeing that under X-ray imaging. And then afterwards, we go ahead and put in the cement. And as you can see, she did really well. She was discharged. She was pretty much could have went home the next day, but we kept her for 1 more day and went home. And then I saw her in clinic 2 weeks afterwards, and her pain went from a 9 to a 3. She was able to be more functional on her own, and she was only taking Tylenol without any other pain medicine. So the clinical evidence. So greater pain reduction compared to non-surgical management, greater movement if you look at patients in 1 month having the procedure versus not having the procedure, fewer days of restricted activity, and then a big thing, 57% decrease in taking narcotic medication. And then on the graph here you could see, so quality of life, which is the main reason we're doing this, so 7.2 versus 1.8. More data. So discharge to home sooner, readmission rates less, stay in the hospital less. Outcomes are excellent for this procedure if you've got to pick the right patients, and that's what we do. We know, where we're treating patients that have significant quality of life issues, and the pain relief is about 95% in most studies. Complications are very low, less than 2%. And so one thing that does come up from time to time, and most of it is my conversations with patients and sometimes providers, then they say, well, my other doctor told me that we shouldn't really do this procedure because if we do this, it's going to cause me more fractures. So there's a thought that the strengthening the vertebral body is all of a sudden going to lead to more fractures in other bones, either above or below. And so there's really no proof, and in fact, the proof's kind of opposite. And so there's data out there that shows that it's not related to the repair, and treating a vertebral body actually protects against height loss and decreases the risk of new fractures. And the main culprit for patients developing new fractures is the underlying process, which is osteoporosis. And so a single fracture, a patient's 5 times increased risk of developing a new fracture. If they have 2 fractures, they're 12 times increased. If you have 3 fractures, it's a 75 increased risk of developing other fractures. So when I hear that, I basically tell patients and providers that the benefit of treatment far outweighs the risk of sitting on a fracture where a patient's not able to function. So here's another case, and kind of with the same theme of where there's a delayed in treatment. 77-year-old man, he injured his back coming out of a car. This was 6 months ago. And he was seeing his general provider, seeing orthopedic surgery, and eventually made his way to me after 6 months of dealing with this pain and really limiting his life. So we went ahead and got him into the interventional suite. And what I want to show you is the advantages of increasing the vertebral body height. So this is before the balloon, and it's measuring 25 millimeters, and this is after 29. And so just that difference of increasing the vertebral height causes a significant benefit in patients. This is afterwards with the cement within the vertebral body, and he did great. He was very relieved. We saw him in the clinic about a week afterwards. Very thankful. And there was a discussion about why it took so long. And so what I told him is that he's at risk for more fractures. And so the next time he should come talk to us first. Here's another example of a patient that I just wanted to show you the significant improvement in height. So the MRI showing the wedge compression fracture. And here we are doing the procedure. And then afterwards, the cement inside the vertebral body, and you can see the difference in the vertebral body height. And this patient also had a very good outcome. So kyphoplasty, it's more effective than non-surgical management. It's supported in the literature. It prolongs survival, proven, and it prevents that spiral that I talked about. So the big thing that I want to kind of address to everybody here and even people out there on Facebook is that treat early. And treating early doesn't mean you could still wait a little bit to see maybe how patients fall in, but 2 to 3 weeks versus 2 to 3 months or 6 months. So in conclusion, it's proven to decrease back pain and improve quality of life, and it also decreases patients' risk of death And it's up to the public to be their own advocate and to ask questions about options. And everybody has Google now, so if you get a fracture, you Google it. See what it says. Ask your doctor what about this treatment? And I think it's really important for us to do these procedures here at Concord Hospital, and I think we add tremendous value to our community because of this. Thank you.
You said that you really don't do this unless someone's in pain. But if they have a fracture, and it looks like it includes a whole bunch of things, including height, which I'm looking forward to, why wouldn't you just go do it?
So the improvement,
You have to be in pain.
so you have to be in pain. And the improvement in height is we're not going to get you a few more inches if we put in a lot of cement. So it's really only for symptomatic compression fractures.
But if you've lost height because of your osteoporosis, and you've got the fracture, but you're not in pain, you wouldn't do it.
Would not do it. If there's not any pain, if you're not even, for example, somebody I saw this week came into my office and had a compression fracture, and he was well dressed, he wasn't fidgety, he was able to explain to me all the exercises that he was performing at home, more than that I am doing. And I said, you know what, I don't think you're a great candidate for this. It's somebody that's in significant pain, quality of life issues. That's when this treatment makes sense. Yeah.
So I have a relative who has turned away from invasive surgery because of medical issues, and I was wondering what kind of patient this allows and what are the limits on the kyphoplasty. Who would you turn away?
So I would turn away somebody that doesn't have significant pain, and that's about it. Yeah. In most situations, if somebody has significant pain, even if they have where their vertebral body is really thin, then I can do something where I use both procedures, vertebroplasty, but instead of using the cement that was thin that I used to use when I did vertebroplasty, I would use the thicker cement in those patients. The only real contraindications would be if the vertebral body is at a point where it's pushing against the spinal cord, and so I'm concerned that it may even move more towards that, and so I would be hesitant about doing those patients. Yeah. Sure.
On the case number one, that woman had two fractures. Would you do both fractures at the same time?
Yes, I would do, and we did. And I think the most I've ever done at one sitting was 5. Yeah. So there's a disease process called multiple myeloma, and so it's kind of like really bad osteoporosis. So it's like the cancer that I kind of take over the whole vertebral bodies, and they'll all become narrowed. And so there's been times where, with the help of sometimes radiation, but we've went ahead and I've treated from the thoracic vertebral body 6 all the way down to L5, and all because they would keep coming back with new fractures. But it's pretty rare, but you can do multiple at once, and then we did that for that patient. Yeah.
I just got a question. When you mentioned coming in from 2 sides and then one side, when you're doing this, how do you know you're not getting through nerve roots coming out from the sides or even near the spinal cord? Are you doing this under straight fluoro?
Yes. So we're directing straight fluoro.
You can't see the nerves.
So we can't see the nerves, but what we're guiding so that we're going straight through the pedicle. So there's a front part.
Get in the bone to get into the bone.
Correct, yeah. So there's a front part of the vertebral body and a back part, and then it's connected by a little bridge that's called the pedicles. And so you can see those, and they look like a circle on the X-ray machine, and then we go right through those circles right to, so we're trying to stay out of any nerves, arteries, and so that's how we do it. And so in the past, when I used to do this, maybe about 10 years ago, I would always go from both sides and kind of meet in the middle. And now, what we do is we try to go from one side and kind of go straight into the middle. And so it decreases the incision site, it decreases the duration of the procedure, there's less bruising and just from getting in with the small little needles. And that tiny incision, we put Band-Aids afterwards. And the patients then go up to recovery for about 2 hours, and most patients go home same day. Sure.
What if someone has had a compression fracture that they've healed, but it didn't heal properly? How old of a fracture could you treat with this?
Yeah, so there's times, just like the gentleman that I showed with 6 months, where you'd say, okay, well, probably at 6 months, most people would have a healed fracture. But it's not always the case, because it could be like constant shifting and like micro little fractures going on. And if that's the case, then we would go ahead and we would treat them. And even if you had that out at a year, I would still treat them. And so what I base everything off of is the symptoms and then the MRI. So if the MRI shows that vertebral body is lighting up like a light bulb, and then I push right on that back, right at that area, and the patient says, yep, that's it, that's the point of where it hurts, then I don't have any hesitation to even do it out for a few years, and I have done that.
Does the pain have to be constant, or can it be based on activity, like you stand up for 5 minutes and then you have to lie down?
Yeah, so that's a great question. So I remember a gentleman, I did his mid-50s in age, and he had a fall shoveling snow. And so the winter was over, and he was still suffering with pain. And he said he came in, he was well-dressed, he was working in the office, and he's like, I pretty much could do everything I want to do in life, but I can't golf. Just the movement, everything's problematic, and I have pain with activity. So we went ahead and I treated him. And it was a significant benefit, where it was kind of like this smoldering fracture, and we were able to treat. And so there's so in those situations, it's really comes to a discussion, with my team, and saying, how significant is your quality of life being hampered because of this fracture? And if you're not able to do what you want to do, then you're a candidate, and we could try to help. Great. Well, thank you, everyone. Yeah.